All right, welcome back. I hope that most of you have had a chance to watch the little orientation video, which pretty short, but had a few things that I normally say in the first few minutes of the lecture. So if you haven't watched that, watch it later today. So we're going to dive right in these two lectures. We're going to go over a lot of names and terminology. I'm going to try to give you enough clinical information to make it interesting, but we need to start in this course really getting the names down. And so this can get towards the end of the second hour. You can easily get on overload, but I just want to reassure all of you that when you come to the end of this block and you look back on this lecture, you will think, oh, that's too basic. I don't think I need to relook at that lecture, because we'll be going over this a number of different times. So as I mentioned, orientation, the way this course is designed is with a concept called planned redundancy, okay, where we go over things several times, multiple times, the important things, so that hopefully it gets kind of laid down on your hard drive for the long term. So again, in this lecture, parts, nomenclature, the plumbing, and just a little bit of clinical information as we go along. So let's start a little bit here with kind of the embryologic division of the central nervous system, which consists of the brain and the spinal cord. Okay, so the brain we can divide into a cerebrum and a brainstem. Okay, the cerebrum is equivalent embryologically with the prosencephalon. And we break the prosencephalon down into telencephalic and diencephalic structures. And in this lecture, we will spend our entire time on the cerebral cortex, and we'll get a little bit into white matter. That's as far as we're going to get here in the first hour. And then we're going to get through all the rest of it here in the second hour. Okay, so telencephalic structures, in terms of the adult derivatives, is the cortex of the brain, white matter, basal ganglia, limbic system, and olfactory system. The other part of the prosencephalon are diencephalic structures, which you can easily remember as anything with the word thalamus in it. Okay, so we have the thalamus itself, but then we have the subthalamus, hypothalamus, and epithalamus. Okay, in terms of the brainstem, embryologically, we have the mesencephalon, which is equivalent with the midbrain. So we can really use those two terms interchangeably. And the rhombencephalon, which is divided into a metencephalon, which is the pons and cerebellum, and the myelencephalon, which is equivalent with the medulla. Now on Thursday, and I recorded this lecture last week for Thursday, we go over the ventricular system, where cerebral spinal fluid is made. And so with all of these, it's important, especially when we're doing our brain dissection labs, when we look at MRI and CT scans, and we look at these fluid-filled spaces of the brain, we'll want to associate the lateral ventricles with the telencephalic structures. Okay, we'll associate the third ventricle with the diencephalic structures. And this is actually really helpful, because the third ventricle, you'll see later on, it's so distinctive. It's like a midline fluid-filled space. And so you may be disoriented, you haven't put things together yet, but you can at least recognize that the third ventricle. And then right away, you know, any structures around it has to be part of the diencephalon. Okay, we'll see when we look at the midbrain that there's a cerebral aqueduct that runs through that. And then the fourth ventricle, we will look for these structures, pons, cerebellum, and medulla around the fourth ventricle. Okay, so a little bit of a grainy picture here, but in terms of the big picture, the white is all of the telencephalic structures. That's why this whole lecture is telencephalon. Okay, the diencephalon is in this area here. Mesencephalon, remember that's equivalent with the midbrain. Myelencephalon, which is pons and cerebellum, and then you have the myelencephalon here is the medulla. Did I say myelencephalon? Metencephalon is the pons and the cerebellum. Now, having said that about the embryologic subdivisions, from here on in the course, whenever I say brainstem, it will be how we refer to the brainstem clinically. which is the midbrain, pons, and medulla. And before the first exam, we have an hour lecture on the medulla, hour lecture on the pons, hour lecture on the midbrain. And so when I say brainstem, I mean one of those three structures, and we'll refer to the cerebellum separately. All right, so let's start with the telencephalon, starting with the cortex. Okay, and all the drawings in this handout were created by medical students over the years, and so we'll have these kind of cartoon drawings that we'll use to identify things. So remember, these are the 5 telencephalic structures, and the cavity we're going to associate with that is the lateral ventricle. Okay, so the cortex of the brain is this 3 to 5 millimeter ribbon that goes all the way around the surface of the brain. So in this section from a year or two ago in our brain dissection lab, you can see the cortex. Notice it dips down, but all of this is the cerebral cortex. Okay, anything that is deep to the cerebral cortex, like right here, we call subcortical. And these terms we will use frequently just clinically. You will hear, well, is it a cortical problem or is it a subcortical problem? Because there are certain conditions that are classically cortical and other conditions that are classically subcortical. Okay, so you'll be familiar with that terminology. Okay, so a gyrus is just a fold. A sulcus is a groove in between a gyrus. And then we have a fissure, which is essentially a really large sulcus. Okay, so when we look at the brain here, you can see, okay, here's a gyrus, and then the groove in between is the sulcus, and here we have a really large one right here. Okay, so we call this a fissure. Okay, we'll identify all of these later, but this is called the Sylvian fissure. And we use all of these to subdivide the brain into different areas, and it will help us to identify important motor, sensory, visual, language areas of the brain. Okay, here is the interhemispheric fissure. Again, a really large one that divides the right and left hemisphere of the brain. Okay, so we use these, and the brain here is kind of turned away from you a little bit, which can make you think the parietal lobe is bigger than the frontal lobe. Frontal lobe is much larger. It's just kind of turned away from you a little bit. But so we have the frontal lobe, temporal lobe, parietal lobe, and the occipital lobe. And we're going to provide a lot of details in all of those. So it turns out because of all of this folding during the development, that 2/3 of the cortex is actually buried deep within these grooves. Okay, and the naming of the frontal, parietal, temporal, occipital lobes a little bit arbitrary and related to the overlying bony structures. Okay, this is about 4 years ago. Someone actually tried to count all of the neurons in the brain. Okay, and they're about equal neuronal and non-neuronal. Okay, don't know why I'm getting that message. Disaster's over. Okay, that's good. So, which is kind of in the realm of the number of stars in the Milky Way, which is kind of cool. I guess I should acknowledge that. Okay. And so again, the terminology, which will mean a lot more to you as you go through the course, when we refer to something as cortical, like Alzheimer's disease would be a classic cortical condition. Entire cortex of the brain is involved in someone with Alzheimer's. So they have lots of problems beyond just memory. Multiple sclerosis is a condition where we have demyelination here of the subcortical myelinated pathways. That would be a classic subcortical condition. And later on, we'll discuss why it is important that we make a distinction, or how we can even make a distinction based on clinical presentation between cortical and a subcortical condition. So let's start with the frontal lobe. Okay, I tried to label all of this in your handout so you can just listen and things are labeled. So in the drawing here, and you will see when you do our brain dissection, it is not always that easy to find the central sulcus. So in our lab on Wednesday, I'll walk you through, and you need to watch the video before also, prior to lab, Here it's easy. Okay, we've got an obvious central sulcus. So this forms the posterior boundary of the frontal lobe. And then we have down here the sylvian or the lateral fissure. We're just from now on going to refer to it as the sylvian fissure because that, I think, is the most common terminology that's used. This is the floor of the frontal lobe. And we'll see here, it's also a floor of the parietal lobe as well. Okay, so these two, a sulcus and a fissure, are important landmarks. Okay, and so anterior to the central sulcus, we have a very important gyrus here called the precentral gyrus. Okay, and the precentral gyrus contains upper motor neurons that are important for activation of movement. And the concept of upper and lower motor neurons will be one of the most central, redundantly repeated areas of this whole course. But just think of, out here on the precentral gyrus, you have upper motor neurons for your face, for your arm, for your hand. And so when you move your face, arm, or hand, that pathway is activated here by these upper motor neurons. What do upper motor neurons do? They talk to lower motor neurons that then actually facilitate the movement. Okay, so if you're moving your arm or hand, okay, upper motor neurons here will talk to the appropriate area of the spinal cord, and that's where your lower motor neurons are, that then move your hand. Okay, so precentral gyrus is here, and the reason we talk so much about upper and lower motor neuron conditions is your examination can easily help you determine, for example, if someone's weak, let's say their hand is weak, we can do specific things like just checking reflexes on examination. And we can easily tell this is an upper motor neuron weakness, this is a lower motor neuron weakness. Okay, so these are really, our exam can easily talk to this part of the nervous system and tell us what's going on. Now, also in the frontal lobe, we have a superior frontal gyrus, a middle frontal gyrus, and an inferior frontal gyrus. And for now, we'll just point out a couple of areas here. On the middle frontal gyrus, we have something called the frontal eye fields. It can be a bit frustrating. A lot of things in neurology have two names. Frontal eye fields is how I'll refer to it, but it can also be called the saccadic gaze center. And this is an area we'll talk about quite a bit because it's important for initiation of horizontal eye movements. Okay, when you look from side to side. Okay, and we can easily assess this part of the brain on our examination. And usually in the left hemisphere, here on the inferior frontal gyrus, notice just kind of anterior here to the precentral gyrus, we have Broca's area, which is the expressive language area. So again, usually on the left hemisphere, even in left-handed people. So the area where you get words out. Okay, and I think on Friday, I'll show you a video of a patient with a lesion here, and you can see what happens when this area of the brain is not working properly. Okay, so that's the lateral surface of the frontal lobe. And again, when we actually look at a real brain, you can see, boy, where is the central sulcus? Well, I'm going to have you hold the brain and we'll tilt it around. We'll look at the inside and I'll give you some clues that will help you to identify here the central sulcus with precentral and a postcentral gyrus that we'll talk about later. Okay, let's say a bit more here about the frontal lobe. This area of the frontal lobe here is called the prefrontal, the lateral prefrontal cortex. And you can see there's a dorsolateral and a ventrolateral prefrontal cortex. Okay, and this area of the brain, every medical student has a highly functioning lateral prefrontal cortex because this area of the brain is involved in task setting. So if you're setting up a plan for the year, a study plan, a schedule for studying for step 1 boards, things like that, that would be a task setting function. And it's also important for monitoring. Are you keeping up with the task? Are you keeping up with your schedule? So these two, kind of work together. And working memory will provide more nuance here to the definition as we go on in the course, but working memory is something that you're doing right now. You have some information, terminologies, things like that. You're taking in new information, you're kind of melding that together to create new memories. And so working memory is a function here of the lateral prefrontal cortex. Now, it turns out if we had to say a difference, the dominant hemisphere is usually the left hemisphere, is more important for task setting. The non-dominant hemisphere, which is usually the right hemisphere, is more important for the monitoring function. Okay, so here is actually a patient who has a right hemisphere lesion, and we're testing the monitoring function here. We're asking him to draw some kind of a square alternating with a triangle structure, and a patient with impaired monitoring will do this for a while, and then they'll kind of forget, what was I supposed to do? And so he kind of mixes it up here. So this would indicate we've got impaired monitoring function, which would suggest more of a right hemisphere lesion. There was a medical student, it was probably 10 years ago or so now, who had a head trauma in between first and second year of medical school. And so all of these were impaired, and it really made it difficult for him in the second year. You know, when task setting, monitoring, working memory, all things that, you know, you need to use all the time are not functioning at an optimal level. Now, if we look at the medial portion of the frontal lobe, okay, do you remember we had that central sulcus on the lateral portion? Well, here it is on the medial portion, okay? And so this area around the central sulcus on the medial portion we call the paracentral lobule, okay? And so if I just move anterior right here, I'm on the precentral gyrus, but now in the medial portion of the hemisphere. So again, we have upper motor neurons here. Remember, that's precentral gyrus. And in just a little bit, I'll show you a picture, but actually the leg and the foot upper motor neurons originate right here from this portion of the precentral gyrus. Okay, another important part of the medial portion of the frontal lobe, you can see we've got a big gyrus right here. This is the cingulate gyrus, okay, which I'll talk more about later. And you can see that right under that, you've got a huge pathway, and this is called the corpus callosum. And the corpus callosum interconnects the right and left hemisphere of the brain. Now, so let's just say we want to just quickly in lab, let's find these areas. Well, if you were just to put your fingers into the interhemispheric fissure and sort of pull them apart, what you're going to find, is, or maybe just put your fingers down into the interhemispheric fissure. Eventually, they're going to rest on the corpus callosum right here. And your fingertips would be lying on the cingulate gyrus. Okay, so here we've done this in lab. You pull them apart, and what do you see? That's the corpus callosum, deep down there. Okay, so what is the gyrus that's lying right on top of the corpus callosum? This would have to be the cingulate gyrus. Okay, so when we go into lab on Wednesday, just some basic things like this that will give you some orientation. Okay, a couple other things about the medial portion here of the frontal lobe. Here we have the superior medial prefrontal cortex, kind of in pink here, and this anterior portion of the cingulate gyrus sort of works together with the superior medial prefrontal cortex. And this part of the brain, maybe the easiest way to say it, it's getting your mental clutch out of neutral. You get motivated, like, okay, I need to study. You get into the study zone, and for 2 days, you're just clicking and everything is really coming together. This is that kind of energizing part of the brain where you can really get into the zone and do something like that. Okay, so if we have lesions here, just think you're losing all that energizing function. And so in extreme case, we can have what's called akinetic mutism, which is quite rare. But patients with this can appear almost like they're in a coma. They don't respond. They don't say anything. Okay, in a less severe form, we can have abulia, which is kind of without joy. They have a very flat affect. You ask them questions. They have kind of a monotone voice as they respond with short answers. You know, they're not elaborating. And apathy would kind of go along with that. Okay, so different lesions of different parts of the frontal lobe gives a very different clinical picture. Now, if we turn the brain upside down, we look at the undersurface of the frontal lobe. Okay, this is called the orbital frontal cortex. Okay, and we can name a few things. There's a straight gyrus here, which literally means the gyrus rectus, the straight gyrus. And you can see just lateral to that, you have the olfactory bulb and tract. We'll get to cranial nerves later, but obviously for smell, olfaction. Okay, and then let's say a little bit about the orbital frontal cortex now. So I'm sure in psychiatry lectures, you will learn much more about this, but as a big picture, the orbital frontal cortex is involved in behavioral, emotional regulation, and social cognition. And so as a neurologist, I see patients that have a condition called a frontotemporal dementia, where they have early involvement of the frontal lobe. And so these patients will present with these types of findings. One is disinhibition. So they just lose the filter. They say inappropriate things, get into arguments easily. Environmental dependency is like a need. Patients I see with this, they come in and they want to touch my shoulder when they're talking to me. They need to like explore the environment and almost grab onto things. And hyperphagia is often it's for sweets. So patients will have weight gain kind of along with this. So I can tell you about a patient I saw, I don't know, within the last 6 months. My first time seeing him, and I'm walking out into the lobby to get him, and I hear some loud argument going on, and my patient is shouting at another veteran, and I just opened the door in time to hear him say something like, you woke people are destroying this country. And it's like, okay, what's going on? And I called him back. On the way back to the room, he made an inappropriate comment about the female medical student who was with me. And I did the exam, and I'm checking reflexes, and he, in a very aggressive way, said, I'd like to hit you with that hammer. So it's like, it was a little bit of a, difficult encounter. He was there with his wife, who said he has a fixation for M&Ms, and he's gained about 30 pounds. And he wanted to kept wanting to sit close to me, so exhibited some environmental dependency. So he had kind of a very typical presentation of a frontotemporal dementia that involved this part of the brain. Now, if we move forward to the kind of the tip of the frontal lobes, we have the frontal poles, and this is involved in what's called metacognitive processing. It's self-awareness, but also awareness of others, the ability to put yourself in someone else's shoes, for example. And so this part of the brain, we're quite good when you know someone and there's just a little lift of the eyebrow or a slight flaring of the nostrils, you can tell, okay, I upset, this person, right? We're quite good at that. Individuals that have lesions here, the frontal poles, are very, very poor at that. And they also tend to have impaired empathy. So this same patient actually who came with his wife, she said, he's always been a very caring person, but then she had breast cancer and he seemed not that concerned, just not the same person. Okay, so again, this whole degeneration of this part of the frontal lobe also involved the frontal poles, and he had impaired empathy. Okay, so again, a poor recognition of facial expression would also be something that you would see along with that. Okay, so now that's just a little preview of the frontal lobe. Let's move back to the parietal lobe. So here we still have the Sylvian fissure, which here forms the floor of the parietal lobe. Okay, and so in the parietal lobe, we now have a post-central gyrus. So we said the precentral gyrus was important. Upper motor neurons are here for movement. The post-central gyrus, when we draw out our sensory pathways, we will see that sensory perception, the ability to feel things in your face, arm, and leg, this is going to the post-central gyrus. Now, again, in a drawing, it's much easier. It looks like it should be easy to identify in the lab. It actually is not that easy frequently. But if you just follow the Sylvian fissure all the way back to its termination, around that, we have the supramarginal gyrus. Okay, this is part of the parietal lobe. And then if we move posterior to that, we have the angular gyrus. Okay, so these two gyri here are part of the parietal lobe. Okay, so the angular gyrus back here matches sounds and visual information to words. And so in just a little bit, we're going to talk about this part of the brain back here, which is called Wernicke's area. This is the part of the brain where you understand what people are saying. Okay, so you can kind of think of the angular gyrus as the gateway to that. And so the example I gave in the handout is about at dusk. Frequently at our place, there's a red-tailed hawk that screeches right over our backyard. Okay, so I hear that, I see it, and I can match the sound and the visual information to, okay, that's a red-tailed hawk, being able to pull up the right word. Okay, so that would be a function here of the angular gyrus. The supramarginal gyrus is more important for visual spatial information, the ability to track that hawk by sound and by vision. So there's overlapping function here, but there's slightly a difference between these two. The angular gyrus on the dominant hemisphere especially is important for math calculation ability. So when we see patients that have a small lesion here, and I'll tell you about that condition later, they can have a sudden drop in math skills. First patient I saw with this was a calculus teacher who came in kind of confused and was very poor at math in the emergency room. And his lesion was right here in the angular gyrus. Now in the medial portion of the parietal lobe, okay, we have the precuneus right here, which extends all the way back to the parietal occipital sulcus. And the parietal occipital sulcus then divides the occipital lobe back here from the parietal lobe, which is this whole area here. So we've talked about the precentral and postcentral gyrus, and the homunculus describes the specific motor and sensory areas along the pre and postcentral gyrus. And I'm serious, you will get probably several national board questions right just from knowing where the motor and sensory cortex is. And so you just need to spend some time with this. And so you can see, for example, that here's on the precentral gyrus, that the face, the lips, I mean, just think of the intricate, just speaking, whistling, things like that. You've got a big representation here. And also the hand has a relatively large representation because obviously, writing, typing, playing an instrument, we need a big motor cortex for the hand. Okay, and here is the postcentral gyrus. We could see the same thing, really big representation for the face and the hand. Okay, now when we dip over into the medial portion of the brain, not shown here, it's shown up here, but the leg and the foot is on that paracentral lobule. Yes? Oh, I may have misspoken here. So this is the precentral gyrus, this is the postcentral gyrus. So I'm sorry, this is motor and this is sensory, right? And you can tell this is more anterior and this is more posterior. Thank you. Okay, so again, that paracentral lobule there on the medial portion is for the leg, and also the student that drew this put some genitals in here also, and also for the control of the bladder as well. So oftentimes with lesions of the paracentral lobule, we'll see leg weakness, and also there will be some incontinence that goes along with that. Okay, so here is a sagittal midline section of the brain. So again, here is the paracentral lobule. Here's the central sulcus. Okay, so this is the precentral. So this would be movement for the leg and foot. And this is the postcentral gyrus, parietal lobe. So this is sensation for the leg and foot. Okay, and as we'll see in neurology, virtually everything is crossed. Some things are crossed twice. Okay, and so this precentral gyrus would move the opposite leg and foot, and this postcentral gyrus would feel the opposite leg and foot. And we'll spend a lot of time on that. Okay, so we've talked about the frontal lobe here, superior, middle, inferior frontal gyrus, the precentral gyrus, and then we've moved back to the parietal lobe with the postcentral gyrus, and going back to the parietal occipital sulcus. Okay, so now let's talk about the temporal lobe. So again, we can use the Sylvian fissure as a landmark here. So it's sort of the roof of the temporal lobe, which has a superior, middle, and an inferior temporal gyrus. Okay, and clinically for now, we'll really only talk about the superior temporal gyrus. Now, first of all, if we were just to, in lab, I'll tell you, put your finger right in the Sylvian fissure right here. And if you do that, your finger will rest on what's called Heschel's gyrus. Okay, so in the next picture I'm going to show you, we actually dissected away this whole part of the brain right here. All of this brain around the Sylvian fissure is called the opercula. Okay, and if we dissect that away, you can see what your fingers are resting on right here. This number 4 is the primary auditory cortex for sound. Okay, otherwise known as Heschel's gyrus. Okay, so it's kind of, it's part of the superior temporal gyrus located right there. Now, I've taken out, we used to teach areas of the brain that are called Brodmann's areas, which I've just decided is probably not that important for you to know. But I'm just going to, if you hear that, the area of the brain was divided into these Brodmann's areas, but that's the last I will say about it. Okay, but I did just want to point out here that so far, what we have talked about here is the Broca's area, right here. Again, the expressive language area. And now we're talking about the superior temporal gyrus. Okay, and so this area of the brain right here on the superior temporal gyrus is called Wernicke's area. And like Broca's area, these two language areas work together. Okay, Wernicke's area is where you understand. Broca's area is where you speak. Okay, and again, these are usually on the left hemisphere. And so we just said if you put your finger into the Sylvian fissure, it's going to rest on Heschel's gyrus. And it kind of makes sense, doesn't it? That the primary auditory cortex is going to be immediately adjacent to the part of the brain that interprets that. Right? So Heschel's gyrus is right next to Wernicke's area. Okay, and then if we move back here, remember if you follow the Sylvian fissure to its termination, you reach these areas of the parietal lobe that we talked about, the supramarginal gyrus here and the angular gyrus back here. Okay, and in just a little bit, we'll talk about a pathway that connects Wernicke's and Broca's area. Okay, again, if we turn the brain upside down, we can identify parts of the temporal lobe. The most medial portion of the temporal lobe in yellow here is called the uncus. Okay, and the area lateral to that is the parahippocampal gyrus. So the uncus is primary olfactory cortex, and you can kind of imagine here's the olfactory bulb and tract. So smell goes right back here to the uncus. Okay, so the student who drew this wrote, to help you, stinkin' uncus. That helps right there. And this area of the brain is also the most epileptic part of the brain. Okay, so when we have any kind of injury, irritation to this part of the brain, seizures can easily occur. And so when a seizure begins here in the uncus, the first symptom the patient will have is a smell that is almost always bad, like burnt rubber kind of a smell. So if you hear that story, then you know, okay, where did the seizure focus begin? It began in the uncus, which is part of the temporal lobe. Parahippocampal gyrus we'll talk about later. This is part of the limbic system, which we'll discuss in just a little bit. Okay, just another very clinically relevant aspect about the uncus. Notice here we have what's called a subdural hematoma. This happens after head trauma. You get some bleeding in the brain. We talk about that on Thursday. And whenever there's increased pressure in the brain, there's just nowhere for pressure to go, really. It has a devastating consequence. And so what happens here is this pressure pushes the uncus towards the midline. Okay, and in the next lecture, we will point out this nerve right here, which is the oculomotor or the third cranial nerve. And so these patients typically would present unresponsive. Okay, and how do you know what's going on? Well, you just look at the eyes, and later on I'll tell you what a third nerve palsy looks like. So a patient who has a third nerve palsy who's in a coma, that's a really bad finding. Okay, that means that patient has uncal herniation. Not many patients survive from uncal herniation, but it's something quick. Someone rolls into the emergency room, you can identify that third nerve palsy, and you right away have a pretty good idea what's going on. Okay, so over here you can see the uncus. Okay, and then there's the third nerve right next to it. So that relationship between the uncus and the third nerve is really important. Okay, we'll say very little about the occipital lobe. Here's the parietal occipital sulcus. So all of this is occipital lobe, which is much larger on the medial surface of the brain. When we look at it laterally, it's just kind of a little tip there. Okay, and so the large sulcus here you want to be able to identify as the calcarine sulcus, and primary visual cortex is all around this calcarine sulcus. Okay, so later on we'll map out the pathway that goes from the retina right back to primary visual cortex here. So the back of the brain sees. Okay, the area above the calcarine sulcus is called the cuneus. The area below is the lingula. Okay, so if we're just going from bottom to top here, we have the lingula, the cuneus, and then remember, once we move into the parietal lobe, we have the precuneus. Primary visual cortex is otherwise referred to as the striate cortex. Okay, so they're one and the same. Okay, just another drawing here. Parietal occipital sulcus. Okay, cuneus, lingula, and the primary visual cortex all around this calcarine sulcus. In the lab, we'll see these reflections of dura, and there's an important reflection of the dura that goes right in here. It's very important to stabilize the brain. Okay, this is called the cerebellar tentorium. And so just notice that the occipital lobe kind of sits right on top of a structure we'll talk about in the next hour called the cerebellum. Okay, and so you've got this cerebellar tentorium that reflects right in between there. Okay, so it turns out that a massive, more than half of your brain is involved in visual processing. Okay, and so, for example, when you're reading something, yes, it does go back to the occipital lobe, but you don't interpret things there. That's just the primary visual cortex. To actually read, you need to move that vision forward to the temporal lobe, okay, especially to Wernicke's area here. This is actually where you read. Okay, so the vision goes back to the occipital lobe, but the what is it? Identifying an object, looking at a car, knowing what type it is, or looking at a word, being able to, identify the word or someone's face. All of the what is it function goes from the occipital lobe to the temporal lobe, most importantly, Wernicke's area. Okay, the identifying where is something in space. Okay, obviously you need vision for that, right? But that function is a connection between the occipital lobe and the parietal lobe. Like I mentioned, the supramarginal gyrus, remember being able to track and see that bird flying through the air. So that involves needing very important connections that are working, properly between the occipital lobe and the parietal lobe. Now, some textbooks will refer to an insular lobe and a limbic lobe, but really these are just made up of the other 4 lobes of the brain, so I won't have a separate distinction for those. Previously, remember I said if you dissect away the opercula around the Sylvian fissure, I pointed out Heschel's gyrus. Well, it's like there's another little brain inside here. Once you look inside the Sylvian fissure, okay, much smaller gyri, okay, and this is what we call the insular cortex. Okay, and we'll spend some time looking at that in our brain dissection labs. Okay, and I'm not going to say much about what the insular cortex does. It's kind of interesting, though, in patients we see that have had a stroke that involves the insular cortex, especially if it's in the right hemisphere. Those patients will often have some cardiac arrhythmia. So there's even a function of cardiac regulation of the insular cortex. Okay, and the limbic lobe we'll really refer to as a limbic system. So just another picture. Yes, here's Heschel's gyrus, but all the rest of this is your insular cortex. Okay, so that was a quick overview of the cerebral cortex. Any questions before I move on to white matter? Okay. So we divide white matter pathways into projection pathways, which are long pathways, either going out of the brain or coming into the brain. Okay, we have association pathways and commissural pathways. We'll talk about projection pathways first. Again, these are the big pathways. If it's out of the brain, it's efferent. If it's coming into the brain, it's afferent. So for example, we talked about these upper motor neurons in the precentral gyrus. Okay, that pathway going all the way down to move your hand, for example, that would be an efferent projection pathway. The ability to feel your hand on the postcentral gyrus, that would be an afferent projection pathway. Okay, and so these, major highways, not a bad way of thinking of them, travel through the white matter in areas called the corona radiata, and what we'll really spend some time on here at the end of this lecture is the internal capsule. That one is really important. So don't worry about this, but since the terms are used, I'm just going to have this one picture, but not ask you about it. But when we think of white matter out near the surface of the brain, so here's our cortex up here, we have the centrum semiovale, which kind of contains all these different projection fibers. Deeper down, you have the corona radiata. The distinction between the two is kind of blurred. Okay, just to know, these are when radiologists talk about what they find on a scan, they'll talk about the centrum semiovale and the corona radiata. I don't want you to know about it. What I would like you to know, though, is about the internal capsule, because all of these pathways, projection pathways going out, coming in, they all filter through the internal capsule, which is clinically an extremely important part of the brain. So here's the internal capsule. I know you have no reference right now to know where you're at. Just here it is, a big picture to point out it's a deeper area of the brain. Here's the corona radiata higher up. And so you need to know really everything about the internal capsule. And we'll keep coming back to this in multiple different ways throughout the course, because all of the major pathways we'll talk about travel through the internal capsule. Okay, wish I could do a dissection like this. Okay, but here it nicely shows you the cerebral cortex. Okay, and so here are all these subcortical white matter pathways. Yeah, so out near the surface here, you have the centrum semiovale, corona radiata. And what we're going to spend some time on is when they get compacted close together down here in the internal capsule. Okay, so again, I promise you that by the end of the week, this will all be easy. It isn't right now, but here is the internal capsule right here. Okay, and we haven't identified these important structures around it. That's coming up here in just a little bit. But now just to appreciate, it has kind of a V shape. Okay, the bend right here is the genu. And then we have an anterior limb and a posterior limb. Okay, so I had a student make this really nice drawing of the internal capsule. Okay, well, these nuclear structures we will talk about later. For now, let's just talk about what is in the anterior limb, what is in the genu, what is in the posterior limb. So the posterior limb, we'll probably spend the most time talking about it. There are two pathways that travel in the posterior limb of the internal capsule. Here is the pathway we will talk about more times than any other in the entire course. I will probably say this pathway hundreds of times throughout the course. This is the corticospinal tract, and its name tells you what it's doing. It goes from the cortex, and it's headed down to the spinal cord. Okay, when we talked about the precentral gyrus as upper motor neurons, the entirety of the precentral gyrus going down to move your arm and leg is this corticospinal tract. So these are upper motor neurons. that are traveling here through the posterior limb of the internal capsule. So it's just really important you remember they're in the posterior limb. Okay, and keep that in mind because in the next lecture, we're going to follow this pathway as it goes through the midbrain, as it goes through the pons, and it goes through the medulla, corticospinal tract. Now, right adjacent to the corticospinal tract, you have the superior thalamic radiations. And the arrow can be misleading. You might think this pathway is going down. This is just a point to the name, the superior thalamic radiations. But this pathway is conveying all sensation up to your brain, up to the postcentral gyrus. So anything you are going to feel in your face, arm, and leg is going up to the postcentral gyrus here through the superior thalamic radiations. Okay, and so we will talk about stroke syndromes and other things that involve these motor and sensory pathways. Okay, so they're really important. Now, right here at the bend or the genu of the internal capsule, there's only one pathway, and this is the cortical bulbar tract. When you hear the term bulb, think of the brainstem. Okay, so this pathway is how the cortex can communicate with your brainstem to activate appropriate cranial nerves. Okay, if you're going to stick your tongue out or move your face, that is the cortical bulbar tract that is activating appropriate cranial nerves to do that. Okay, and then in the anterior limb, we have three pathways. The only one that relates to anything we've talked about so far is right here, the frontal eye fields. So remember, we saw that on the middle frontal gyrus, and I said that's important for horizontal eye movements. Well, this is that descending pathway. It's traveling down to the part of the brainstem to help you move your eyes. So that goes through the anterior limb. Okay, and these two other pathways we will talk about later, but the cortical pontocerebellar tract is how the brain connects to the cerebellum. That goes through the anterior limb. And then this pathway here called the anterior thalamic radiations, in about 20 minutes, we're going to talk about this pathway as it relates to memory and laying down new memories. Okay, so I know all of this is new information, but I'm just trying to highlight, really spending some time. It will pay off to know what is in and around the internal capsule. Now, an association fiber is just a pathway that connects things on the same side of the brain. And fortunately, there's only one you need to know, and that is the arcuate fasciculus. Okay, and this is the pathway that connects Wernicke's area with Broca's area. And it kind of makes sense that they need to be connected, right? Imagine you're in conversation with someone. They ask you a question. Where did you understand what they asked? Well, you understood that in Wernicke's area, right? But now you need to respond. And so the program then goes from Wernicke's area to Broca's area, and you respond appropriately. And so this pathway here, the arcuate fasciculus, does that. And later on, I'll tell you what happens when you have a lesion of the arcuate fasciculus and how that affects language. Okay, and so here is just a dissection of the arcuate fasciculus. Okay, and then the last slide here, and then we'll take a break. We have commissural fibers, and these are pathways that connect right and left hemisphere of the brain. Okay, so biggest one we already talked about is the corpus callosum. Okay, and so we've already said if you put your fingers into the hemispheric fissure, it's eventually going to rest right on the corpus callosum. Okay, and we will see in the Thursday lecture that the lateral ventricles are right underneath the corpus callosum. Okay, so corpus callosum, we have a little rostrum right here, a genu, a body, and then a splenium back here. And later on, we will talk about different clinical syndromes that can occur if you have a lesion, if you disconnect the right and left hemisphere of the brain. All right, so it's probably a good stopping point here. Let's come back here in 10 minutes.